Imagine walking into your doctor's office and seeing him light up a cigarette while examining your chest x-rays. Picture your GP writing you a prescription for amphetamines to help you lose weight, calling them perfectly safe slimming pills. Watch nurses smoking in hospital corridors while pushing medication trolleys. This wasn't some nightmare medical drama. This was British medicine in the 1950s and 60s. If you grew up in Britain during this era, you'll remember a world where house calls were normal, where fathers smoked in delivery rooms, where hospitals carried the permanent smell of cigarettes mixed with antiseptic. Today, many of these practices would be completely illegal. Not just frowned upon, illegal, career-ending, prosecutable offenses. Yet for an entire generation, they were simply part of life. The science was different. The culture was different. The expectations were completely different. Let's start with the most obvious one: smoking. Not just patients smoking, doctors smoking. In consulting rooms, during examinations, while reviewing test results. According to research published in the British Medical Journal, in the early 1950s, over 60% of male doctors smoked regularly. They smoked while seeing patients. They smoked between appointments. Some even smoked during minor surgical procedures. Hospitals were even worse. Patients smoked in their beds. Visitors smoked in waiting rooms. Staff smoked everywhere except operating theatres, and even that rule wasn't always enforced. The Royal College of Physicians didn't publish their landmark report linking smoking to lung cancer until 1962. Before that, smoking was considered, at worst, a harmless habit. At best, some doctors actually recommended it for nerves. Here's what really gets me. Doctors sometimes recommended smoking to pregnant women, to calm their nerves, to manage stress. There were actual medical advertisements showing doctors in white coats holding cigarettes, explaining which brands they preferred. Winston Churchill himself became dependent on Drinamil, nicknamed Purple Hearts after his stroke in 1953. His doctor prescribed them freely. Churchill called them his Morans after his physician, Lord Moran. Amphetamines. Speed. By the 1950s, British chemists were selling amphetamines over the counter. No prescription needed. They acquired the popular name Mother's Little Helper, which tells you everything about how casually they were used. Housewives took them to get through the day. Students took them to study. Workers took them to stay alert. But the medical use was even more widespread. According to research on iatrogenic amphetamine addiction, by the early 1960s, somewhere between 2.2 and 3.3% of all patients receiving amphetamine prescriptions were physically dependent on them. That's doctor-created addiction. GPs prescribed Dexamyl, a combination of amphetamine and barbiturate sedative, for everyday mental and emotional distress, for weight loss, for depression, for fatigue. By 1968, when the Bethlehem Royal Hospital opened dedicated drug dependency units, 90% of patients on the soft drugs ward were amphetamine users. 90%. This gives you an idea of how widespread the problem had become. The hard drugs ward was actually locked because attitudes toward injecting drug users were so severe. Meanwhile, GPs were still writing prescriptions for the very substances causing the addiction epidemic. House calls. When the NHS launched in 1948, home visits were standard practice. If you were ill, you called the doctor and he came to you. Not for emergencies, for everything. Flu, earaches, chronic conditions. The average GP's day involved multiple house calls, often in the evening after surgery hours. According to historical records, the average consultation rate per person per year rose from 2.8 in 1947 to 5.6 in 1950. Demand exploded when healthcare became free at point of use. GPs were overwhelmed. They were doing house calls morning, noon, and night. No appointment systems like we have now. You just rang, and the doctor showed up, eventually. By the 1960s, this system was collapsing under its own weight. The Family Doctor Charter of 1966 finally brought changes. It enabled GPs to claim back 70% of staff costs and 100% of premises costs. This allowed them to hire receptionists and nurses, set up proper appointment systems, and reduce house calls to genuine need. Before that, every sniffle got a house visit. Today, getting a GP to your home requires you to be practically unable to move. Informed consent. This concept barely existed before the 1970s. Doctors operated under what was called medical paternalism. They decided what was best for you, and you didn't question it. You certainly didn't get detailed explanations of risks, benefits, and alternatives. The doctor knew best. End of discussion. According to research on doctor-patient relationships in this era, patients rarely asked questions about their treatment. It wasn't considered appropriate. One study from the early 1960s noted that patients who repeatedly requested explanations about their medications were viewed as difficult or neurotic. Medical records from the period describe patients who, often enough, requests explanations about medication treatment, as if this were problematic behavior. Clinical trials were even worse. Before the thalidomide scandal broke in the early 1960s, the ethical implications of drug testing and side effects weren't seriously debated. Doctors prescribed new medications with serious side effects, but until patients started developing visible symptoms, like tremors similar to Parkinson's disease, little attention was paid. The idea that patients had a right to understand what was being done to them, why, and what the risks were, that came later. Childbirth practices were wild by today's standards. In the 50s and early 60s, fathers weren't even allowed in delivery rooms in most hospitals. But when policies changed and fathers were permitted, nobody told them to stop smoking. So you'd have expectant fathers standing there, cigarette in hand, while their wives gave birth. The smell of smoke mixed with blood and antiseptic. Hospital nurseries had windows that opened into waiting areas where people smoked freely. Smoke would drift into the rooms where newborns slept. Nobody thought twice about it. Midwives sometimes smoked between deliveries. The connection between secondhand smoke and infant health wasn't established until later research in the 70s and 80s. And when mother and baby were back in the ward, visitors smoked. Fathers smoked. Sometimes even the new mothers smoked. Hospital policy only restricted smoking in operating theaters and intensive care units. General wards? Fair game. The Royal College of Physicians' 1962 report on smoking made recommendations, but actual policy changes in hospitals took years, sometimes decades, to implement. Prescription practices in this era were remarkably casual. According to a report published in the Journal of the Royal College of General Practitioners in 1971, between 1965 and 1970, 47.2 million psychotropic drug prescriptions were dispensed under the NHS. That's nearly 50 million prescriptions for mind-altering drugs in just 5 years. Doctors entering practice in the late 50s and early 60s had few pharmacological choices. GPs primarily used a range of tonics, dispensed in various colors and available in different strengths. Then suddenly, in the mid-60s, there was an explosion of new drugs. Tranquilizers, antidepressants, sedatives. And doctors were ill-prepared for this sudden increase in therapeutic preparations. The result? Massive overprescribing. People would visit their GP for anxiety about work and leave with benzodiazepines. Trouble sleeping? Barbiturates. Feeling down? Amphetamines to perk you up. The pharmaceutical industry was advertising heavily to doctors. Medical journals were filled with drug advertisements making bold claims, and GPs, overwhelmed with patients and lacking time for lengthy consultations, reached for the prescription pad. Mental health treatment in this era was brutal by modern standards. Electroconvulsive therapy, ECT, was the most frequently used cure in the late 1940s. While its use decreased from the second half of the 1950s, it was still common. And the way it was administered then versus now? Completely different. Less anesthetic, more physical restraint. Consent procedures that barely existed. By the late 1960s, nearly 9 out of 10 psychiatric patients received psychotropic drugs. The introduction of medications like Largactil, the British name for chlorpromazine, was considered revolutionary. But the side effects were serious. Patients developed tremors similar to Parkinson's disease. They complained constantly about unwanted physical reactions, stomach aches, headaches, sleep problems. But here's the thing. Before the thalidomide scandal, which broke in the early 1960s, the ethical implications of side effects weren't seriously debated among medical doctors. Physicians weren't in regular contact with the drugs themselves, so at first they paid little attention to what patients were experiencing. Patient complaints were often dismissed as part of their mental illness, rather than legitimate medication reactions. Hygiene standards were shockingly basic. The Collings report from 1950 described dirty and ill-equipped consulting rooms with rusty and dusty antique instruments in some GP practices. This report concluded that the overall state of general practice is bad and still deteriorating. It triggered angry responses from the profession, but the criticisms were largely accurate. Reusable equipment was standard. Glass syringes were used, sterilized by boiling, and used again. Disposable needles weren't widely adopted until the 1960s. The risk of cross-contamination was significant, though less understood than today. Hospitals had sterilization rooms where equipment would be cleaned and reused. The concept of single-use medical supplies was just beginning to emerge. Hospital ward design contributed to infection spread. Open wards with beds in long rows, minimal barriers between patients, curtains that were rarely changed. Visiting hours were restricted partly for infection control, but the standards within the hospital itself were rudimentary compared to today. Antibiotics were available, which helped, but hospital-acquired infections were common and often serious. Doctor working conditions were extreme. According to testimony from doctors who worked in the 1970s, junior doctors regularly worked over 120 hours per week. 120 hours. That's 17 hours a day, 7 days a week. They were on 1 in 1.5 rotas, meaning they had one night off in 3 and every third weekend off. After 80 hours worked, doctors were paid at 1/3 rate until 120 hours. The rate after 120 hours was even less. Sleep deprivation was endemic. Doctors would nap in on-call rooms between emergencies. Medical errors due to exhaustion were inevitable, though rarely discussed publicly. The culture was that you simply powered through. The NHS couldn't have functioned without overseas doctors. Enoch Powell, serving as health minister in the early 1960s, launched a campaign to recruit doctors from overseas. He succeeded in attracting 18,000 from India and Pakistan alone. By 1968, nearly half of all hospital doctors below consultant rank came from abroad. These doctors filled gaps in unpopular locations and specialties that British-trained doctors avoided. Patient rights, as we understand them today, simply didn't exist. Privacy was minimal. Doctors discussed cases in open wards where other patients could hear. Diagnoses, including terminal ones, were sometimes delivered with other people present. The concept of patient dignity was discussed in medical schools, but practical implementation was inconsistent.
Teaching hospitals used patients for medical education with minimal consent. Students would examine patients, practice procedures, observe surgeries, all without the detailed consent processes required today. Patients understood they were in a teaching hospital, but the extent of their involvement in education wasn't always clear. You were there to be treated, and being a teaching case was part of the deal. Complaint mechanisms were primitive.
If you wanted to complain about your care, there was no clear process. You could write to the hospital administrator or the Family Practitioner Committee for GP complaints, but these were often dismissed or minimized. The idea of patient advocacy, formal complaint procedures, or compensation for medical negligence was just beginning to develop.
So there you have it. Shocking things British doctors once did that would be completely illegal today.
Smoking in hospitals, prescribing amphetamines casually, delivering babies while fathers smoked in the room, minimal informed consent, working impossible hours, reusing medical equipment, operating without clear patient rights frameworks.
But here's what's important to understand. These doctors weren't monsters. They weren't deliberately harming patients. They were working within the scientific knowledge, cultural expectations, and regulatory framework of their time. The link between smoking and cancer wasn't fully established until the 1960s. Amphetamine addiction wasn't understood as iatrogenic. Informed consent wasn't yet a developed legal concept. The Medical Act of 1950 introduced disciplinary boards and improved medical regulation.
The 1960s brought changes in attitudes toward public health. The 1970s saw the beginning of patient rights movements. The 1980s brought awareness of medical errors and overwork. Each decade built on the previous one's mistakes and lessons.
Today's NHS, despite all its problems, operates under vastly stricter regulations. Informed consent is mandatory. Patient rights are enshrined in law. Working hours are regulated. Smoking is banned. Prescription practices are monitored. Medical devices are single-use or rigorously sterilized. None of this was guaranteed in the 1950s and 60s. If you lived through this era, these practices won't surprise you.
You'll remember the smell of hospitals, the authoritarian doctors, the casual smoking, the lack of privacy, and you probably survived despite it all. If you're younger, this will seem like ancient history, but it was only 40 or 50 years ago. Your parents or grandparents experienced this healthcare system.
The progress is real, but it didn't happen automatically.
Every regulation we have today exists because someone identified a problem, gathered evidence, fought for change, and eventually convinced policymakers to act. From recognizing amphetamine addiction to banning smoking in hospitals to establishing informed consent, each protection came from documented harm and determined advocacy. Makes you wonder what we're doing now in 2025 that future generations will look back on with horror. What current practices will seem barbaric in 50 years? Time will tell. But hopefully we'll keep learning, keep improving, and keep putting patient safety and dignity first. If this shocked you, hit that like button. Subscribe for more historical deep dives into British medical and social history. And comment below. Did you or your parents experience this era of British medicine? What stories do you have? I want to hear them. Thanks for watching.